Hi, my name is Ikra. I'm a student occupational therapist at Coventry University. I'm on my second year. Uh, and I worked alongside Shani and Oyin to carry out ward-based activities on the ward with elderly adults. And this presentation will kind of just run through how our group was structured, how it was set up, and kind of just reflect on the first session and the second session and improvements made and improvements to be made in the future. And next slide, sorry.
So, what are we discussing today? First, we'll run through why we chose to carry out an OT ward-based group activity, then how an OT group-based activity can improve health and well-being of older adults in an acute inpatient setting, followed by the risk assessments, followed by the patient information gathered, risk assessments completed, and clinical reasoning used. We then apply the PEOP model to our patients, outline the 3 group activities we did, followed by our reflections on the first and second session, a Kahoot, not a Kahoot, evaluation, and then a Kahoot if we have time.
Next slide, please. So hello everyone, my name's Shani and I'm also a second year occupational therapy student along with Ikra and Oyin at Coventry. So why did we choose to run this group? So as we age, health and well-being becomes increasingly important, and this is especially true during times of acute care for our patients. And so we believe that ward-based group OT activities are essential for improving the quality of life for older adults whilst they're staying in hospital. And as you know, as occupational therapists, we hold the belief that engagement in occupation is fundamental to a person's health and well-being. So by participating in ward-based group activities, patients can hopefully improve their physical, cognitive and emotional health and well-being, whilst also fostering social connections. And by encouraging our patients to engage in different roles as part of our group, we can enhance their quality of life and then even help them identify meaningful goals for when we see them later in our therapy. Next slide, please. So how can our group improve health and well-being in older adults? So according to Duncan, when a person is unable to do the ordinary everyday things that they want or need to do, they can experience occupational dysfunction. And we recognise that a lot of patients on the ward are unable to do their everyday activities because they're in an unfamiliar environment. They're away from home, they're away from all of their family and friends and their usual activities. And Duncan also states that a person's ability to carry out daily tasks is directly influenced by their interaction with their surroundings and the activities that they undertake. And this is known as occupational competency. So our group enables our patients to engage in everyday occupations by promoting social engagement, stimulating cognitive functioning, whether this is using tasks that involve memory skills or promotes functional skills in gross or fine motor skills within the hospital environment. Next slide, please. Here is the OTIPM. This is the Occupational Therapy Intervention Process Model, and this is the model that we've been using by Fisher and Martorella at Coventry University. I know some of you might be more familiar with the CREAK model, and our process starts with our group by the referrals that come in and by gathering initial information, which is highlighted in the little yellow box. And we use this because we use the OTIPM, which is what it's abbreviated to, as it's a top-down, client-centered process model. So it helps us think about occupation throughout the entire process. Next slide, please. So before any patient was given any or before any patient was spoken to or joined in our group, we gained informed consent, which aligns with our RCOT standards. Ikra, I don't know if this was your slide. If you want to
Sorry, yeah, it was mine. So during our initial contact with the patients, we had brief conversations with them about their interests, pasts, goals, and lots more. We then went away and did a bit of digging into their medical records and social histories to gain better diagnostic reasoning as to why they're in the hospital and what other conditions they may be suffering with, which we may need to accommodate during the session. In addition to this, we checked PICS, which is a system used in the trust, to find out what their OBS were, their news 2 scores, medications, etc. prior to the session. We also used information from donor meetings the day prior to gain an understanding of the patients from different MDT perspectives. Finally, we had opportunities to further build rapport with the patients during therapy so they feel more comfortable with us during our group session. Next slide, please.
Before carrying out our group activity, aside from the information gathering, we also had to do a lot of risk assessment. So, for example, we gained informed consent and explained what we were doing and why we were doing it, ensuring that the patients did consent to the activities that were being carried out, and if not, that was accommodated to. We also thought pragmatically, ensuring the patients were assisted, if they needed to go to the toilet prior to the session, given any drinks, tea, water, checking their blood pressure and their OBS before commencing our activity to ensure that it was carried out safely. We also checked to see if our patients were due for any scans or x-rays, and liaising with the nurses to kind of ensure that they were given their correct medications on time, and also liaising with the therapy staff and the nursing team that we were going to be on the ward in the bay doing a session. So if it was possible, if they could carry out whatever needs to be done just prior to the session so that our session wasn't getting interrupted, because when it's interrupted, the patients aren't as focused, and then it just feels kind of disorientated. We also asked our patients prefer to sit out in their chairs to promote functional ability. And if they wanted to stay in the bed, we'd obviously ensure that we stayed near them. We also ensured that patients had appropriate hearing aids, glasses, or any sort of equipment. And we ensured that we cleaned their tables and their equipment prior to the group starting to prevent any sort of spread of infections. Next slide, please. Throughout the entire process, from the very beginning to the very end of our session, this includes the information gathering and the risk assessing. Of course, we used clinical reasoning. When choosing our activities, diagnostic reasoning kind of helped us think about the occupational performance problems the clients might have. They helped us understand their medical history in depth a little more, allowing us to accommodate our activities to any sort of deficits that we may come across. Pragmatic reasoning helped us think about the therapy space and the equipment needed that we had, as well as the time and the environment that we were in. And we also graded activities to the right level of difficulty to ensure that patients were able to show their skills and carry out the activities without feeling discouraged, but at the same time empowering them to be as independent as possible. Next slide, please.
Okay, so here is a graphic representation of the PEOP model, known as the Person, Environment, Occupation Performance Model, which is from Turpin and Iowama 2011. And the PEOP model helps us think about the intrinsic factors, so the internal factors, and the extrinsic factors, or the environmental factors, and how of a person and their environment, and how we can promote occupational performance and participation. So we look at this model and we use it on the whole group. We may even use it individually, but we chose this because it's client-centered and it puts occupational participation at the center, so how well somebody's able to participate in our group. And as you can see from the model, we've got various arrows coming out. If we look at the person intrinsic factors first, I'll start at the top with physiological factors. So we had to think about physiological factors, whether someone was able to mobilise, if they were functionally independent or not, their endurance, their range of motion, and their fine and gross motor skills. This is particularly important because if we're playing any games that involve hand-eye coordination, like throwing and catching a ball, or we need them to sit out, we need to think about the activities that we're doing and the physiological factors of that person. Cognitively, excuse me, we need to think about a person's memory. So are they able to organise themselves with a task that we give them in the group activity? Can they sequence that task? Do they have the ability to hold their attention or follow instructions? And this is a great opportunity as well, because even if we believe that they can, this group can provide you with so much more information and then help you to develop that patient's goal further when you're in therapy with them past the group. And psychologically, you know, it helps us think about, you really do get to know a lot about people's interests and values and their personality traits. That helps to improve their well-being, and you get to find out what patients actually value and what they enjoy from the group, and or what they want to get out of the group as well. Environmentally, thinking about, we'll start at the top where it says social support in the environment. So thinking about the social support, and this isn't just about their family or friends that may be joining them for the group, because we did have family join, but also maybe the emotional guidance that they may need, what support they were having at home, what support that might translate to when we're carrying out a group, and what certain tasks they might need support with. So do we have the right staff in the environment to support those patients? Also thinking about the built environment and technology. The design of a hospital ward has a lot of sensory features. There's lots of noises from others. There's people who are not particularly well. We actually perform this in one bay at a time. So we have to be aware of any other noises that are coming from people. Some people don't wish to be disturbed. How quiet is the area? How noisy? What's the lighting like? Can they see? And think about how that translates from their normal environment. So, and how the everyday occupations they carry out in the home, you know, how would they normally have carried that out at home in this ward environment, because it's very different. And all these factors come together to help us think about their performance and their participation. Next slide, please. Okay, so as you can see, we're back on the occupational therapy intervention process model, or the OTIPM, and we're now going to move into the intervention phase. And this is again showing us, you can't see very well maybe on that slide, but this intervention phase highlighted in green, if some of you are familiar with the Fisher and Martorella, it can show different types of models that we used, and we took a bit of a mixed models approach with our group. It was educational. You know, we're teaching people to improve their health and well-being. It's also restorative, as well as helping our patients acquire maybe new skills or relearn old ones that they might have done. Next slide, please. Okay, so I'm going to begin. I'm going to start by explaining the warm-up activity, and then I will pass on to Oyin and Ikra, who will respectively describe what they have carried out for the main activity and the cool down. So next slide, please. We begin with a reminiscence activity for the warm-up. And the warm-up activity actually incorporates some evidence-based practices by utilising what's known as reminiscence therapy. And this has been shown to improve mood, cognition, and overall well-being in older adults, as per Perez-Sayers et al. 2022. So we did this warm-up activity because we thought about, realistically, it can be completed in any space, small or large. It can be done individually or in groups, and it relies on very little physical resources. So what did we do? Well, we carried out a reminiscence activity that involved talking about informal conversations on various topics like holidays, food, work, and personal moments, aiming to evoke pleasant memories. And like I said, this was done in a group of 4 people, so 4 patients in each bay that we carried out. One was in a male, and then in the second group, we carried out in a female bay with 3 patients. Reminiscence therapy is suitable for use in patients with neurocognitive disorders. It can be adjusted to suit, but people with Alzheimer's, dementia, this is also suitable for. It improves mood by promoting communication and connection with other patients. And it also improves something that is called semantic and episodic autobiographical memory. So it's your long-term memory, it helps improve. And what we actually did was we used an inflatable beach ball, a very small one, which had 6 colours on it. And we made it into a little fun game that improved not only cognitive, but also functional activity as well. And we threw the ball between each patient and ourselves, and we would get them to pick a colour. And the colour was related to informal topics such as childhood memories. These were also graded, so some of the questions were open-ended or closed, depending on the level of cognition that a patient had. And it gave people options to choose from, such as, do you prefer walking in the park or walking in the beach? Would you prefer baking or solving puzzles? And it was very, very simple. Like I said, it was informal conversations, and it really was pragmatically, it was a good choice, as it can be changed to suit any setting, and it's a fairly easy task that can be done. And it also promoted real improvement in patients' mood. They absolutely came alive when they started to have a chat with one another and get to know them. It was really great to see. So it worked really well for both our male and our female side. So I'm going to pass you over to Oya now, and she will discuss the main activity. Next slide, please.
Hiya. Next slide, please. So origami, the art of paper folding, was the main activity of our session. As engaging in activities that require learning, practicing new skills can help maintain cognitive function and provide mental stimulation. It helps develop hand-eye coordination, fine motor skills, mental concentration. Following instructions, learning new skills and activities challenges us at a cognitive level. The use of our hand directly stimulates areas of our brain, as well as our memory, nonverbal thinking, attention, 3D comprehension, and imagination. Resources needed was paper, depending on the ability of the group. It can go from A4 to A3. Instructions, written, verbal, or visual. A table to fold the paper on, music to keep the good vibes going, feedback sheet at the end of the session, as well as a number of staff. The size of the paper and color can be adapted to suitability and needs of the group. Bigger/smaller paper or high contrast paper can be used as needed, as some patients may struggle visually to see the paper. Pre-folded paper can be used to assist those who struggle with manual dexterity, so it's just a little added assistance there. There's also one-to-one assistance. Each patient had at least one person there to sit, to chat, and to help them. So if they needed anything, we were there to help them with that. There was also verbal, written, and visual instructions/demonstrations, so to make sure that the patients had the best chances possible to understand and participate in the group. And we were also able to grade the activity depending on the amount of steps or the actual outcome of the origami itself. So, for example, folding a paper hat has less steps in it than folding a rabbit for Easter, for example. Next slide, please.
Next slide, please. So just to end off our entire activity session, we decided to do something that was a lot more individual and patient-centered, in the sense of we all kind of distribute ourselves to one of the beds in the bay, and we decided to carry out a sort of gaming interactive one-to-one session where we kind of empowered the patient to kind of make choices with what they wanted to do at for the end of the session, whether they wanted to play a board game or a card game, or whether they wanted to just talk. So engaging in board and card games has shown to be effective in improving the cognitive function. It allows for a positive impact on cognitive processes, such as verbal fluency and impulsivity skills. It helps in improving attention span and working short-term and long-term memory in elderly adults. It also took into consideration patient preferences, allowing for further application of a patient-centered approach. A lot of the time we found that when we interacted with the patients, they frequently talked about how lonely it gets on the ward and how they often feel isolated and like they don't have anyone to talk to. So rather than playing a board game or any sort of card game, they preferred to just have a conversation and kind of talk about topics of interest, maybe their past, any hobbies they enjoyed, and things like that. So the resources needed were, of course, card games, board games, puzzles, pen and paper, and of course, not to say that we are resources, but we were our engagement with the patient was the most important thing for this part of the activity. We, of course, because there was only 3 of us and there was 4 beds, we had to, of course, liaise with our student PTs and student dietitians to kind of help us. And so we worked as a team to kind of distribute ourselves among the bays and just get to know our patients, talk to them, have that one-to-one conversation, which not only helped with their cognitive process, but it was really good for their health and well-being, and their mood was highly improved throughout the session. In terms of grading the activity, we adjusted the methods of communications based on the deficits. So, for example, we used non-verbal, maybe written down, using gestures, speaking louder, adjusting our tone of voice and volume, as well as seeing if a patient struggles with hearing, being seated closer to them would be more beneficial, and adjusting resources. If a patient struggled with fine motor skills, providing items or games that allowed for better use of their fine motor skills that were easier to hold, or if a patient had struggled with like issues with their sight, like writing bigger or giving resources that they could see clearly and colors they could see clearly. Next slide, please.
Okay, so moving on to our reflections of the first and second session. Next slide, please. Yep, sorry, just 2 seconds. Okay, so what happened? We were quite disorganized as it was our first time doing an occupational therapy group on the ward. So we were stressed. So we were quite stressed and nervous. This led to poor communication and teamwork prior, resulting in a slow start to the session. Next time, clear communication and delegation of tasks will allow us to start the sessions faster. One thing we did do quite well was grading the activities. Although we felt unsure whether the difficulty of the tasks would match the cognitive ability of the group, the activities that we chose were at the right level to ensure that they were motivated and interested. Next time, we think spending longer with the patients to allow us to better gauge their cognitive ability would increase their participation. Another aspect that we did well in was collaborating with people outside of our group, i.e. the dietetics and PT students. They helped us cover our staff shortage for the activities, and we were relieved that other patients had someone to talk to and help them if needed during the activity. This allowed for better management of the session, and as it ensured all the patients had someone to assist them, maintaining the flow of the session. We could have given the PTs and dietetic students a clearer outline of the activities as they were briefed just before the session started. We felt we were quite comfortable with each other, so our teamwork was quite good during the session. This allowed us to work together to create a positive environment between ourselves and the patients. To improve this further, we could have liaised with each other more so that we had a clear understanding of timings and delegation of tasks prior to the session. Next slide, please.
So during the second session, we felt that the group was a lot better, which is of course quite good to see, and also is quite good in the sense of this is what reflection provides. Reflecting prior to the first session allowed us to have such a good session the second time around. So one of the key things that we found were quite good was our structure had improved and our organization was a lot better. And this was due to prioritizing the right things in terms of time management and preparation. We ensured that we kind of communicated with each other what kind of delegating tasks to each other, kind of talking about what time things should be carried out, when should we go onto the ward, when should we start letting the nurses know that we're going to be on that ward today, and things like that. This of course led to a reduction in stress, and it kind of increased our confidence because we were a lot more organized, and so we had that sort of reassurance that the session would go a lot better as we all kind of knew what we were doing and when things would be done. We found that our improvisation and flexibility was also quite good because, of course, being on a ward, there's always going to be unavoidable circumstances. We did have one of the patients on the bay who became really increasingly unwell, and so one of us had to kind of communicate with each other, and one of us just sat with her to keep her company, as that she did request that. And we also had a patient who had macular degeneration, and Shani did sit with that patient to kind of changed any sort of equipment that was given to allow for her to be better, the activity to be better suited for her. We in terms of feelings, we felt that we were a lot more prepared and expectant of challenges, which allowed us to adjust better, which was again due to the first session that we had, and due to our time being on the ward. We do understand that being on a hospital ward means unavoidable circumstances in terms of patients' health and stuff like that can go wrong. So I feel like the second time around we were a lot more prepared for that. We prioritized communication and collaboration a lot more this time, and this was throughout the entire process, so the starting, during the activity and the end as well. Not only liaising with each other and ensuring that we were informing of each other of things we would like to carry out and any improvements or anything that needed to be changed in how the session was going to go, but also liaising with the MDT, like I said previously, the therapy team and the nurses on the ward, and the doctors, to kind of just let them know we were going to be in that bay, and just engaging in discussion throughout the session as well to ensure that it was flowing quite well, and that if there were any challenges we were dealing with them as appropriately as we could. This really facilitated the surrounding aspects and heavily contributed to the improved structure, as that constant communication kind of allowed us to fall back on each other and kind of work as a team a lot better, and it really did allow for the second session to go a lot better. And this overall, of course, improved the positive patient engagement. We found that a lot of the patients were very happy leaving the session. We even got compliments from staff on the bay saying that patients' mood had seemed to brighten a lot after the session. Next slide, please.
Okay, so this is our final slide now. So just closing off the whole group conversation. And this part is just evaluating what we could do better if we did it next time. What would we need to consider if we were to do these groups again and provide this service in the acute ward hospitals with older patients? So what would we consider next time? What could we do better? So communicating about the length of timings for each section. So initially, the warm-up activity was short. The patients reacted well to this, so we increased the time that we spent on the warm-up, and we changed some of the timings for the main activities as well as the cool down. And next time we would think about clearly changing these activities. So reminiscence activities was good for our patients with neurocognitive disorders because they have the ability to recall long-term memories, but maybe not so much shorter term. But maybe we would further explore our free resources that we found, maybe incorporating some sensory activities, maybe sharing, if this was a regular thing that we carried out on the ward, we would share this with the wider MDT, communicating this during our MDT meetings regularly to let them know how we've been getting on with our patients and let them know how we've been getting on, which could help with discharge planning. So what other resources would have helped improve our group? And this is the middle column now. So we thought about, if we were to do this regularly, we could maybe provide a timetable for the ward staff to let them know when our groups would be held, at what times, at what days, before or after lunch, to help with the flow of the day. There's a lot of stuff that we need to consider, not just ourselves, in order to improve the patient's well-being. So maybe providing a rota would have helped. Developing a poster to raise awareness of the activity on the ward and its benefits, to let other professions know a bit more about who we are and what we're doing. Raising awareness through MDT meetings, this is called Jonah in this trust. And then pragmatically assessing what days and times this would be reasonable to run. Would this fit into the service? So how did we do as a group? Did we achieve our aims of promoting health and well-being? So we used an outcome measure which involved gathering qualitative information by using some feedback forms, and these are nice and simple, included some feedback and some smiley faces, some symbols, and you'll see on the next slide in a moment what these looked like. And we use these to identify well-being indicators relevant to the group activity. And these included overall mood, how the patients felt, how engaged they were, what did they feel the most engaged with, what didn't they enjoy so much, because that's also important. So maybe next time we could think about establishing a baseline, maybe by observing participants' well-being before the initial group activities and note down their behaviour and interactions before the group. I think this would have maybe helped us identify a different type of outcome, what we could have done in the future. And I think finishing off, realistically, without using our reflections and our reflective practice as students, we wouldn't have been able to improve as much as we did. Reflective practice was really key here. We loved using things like Gibbs' reflective cycle, which we found was a nice, simple one to use. It really helped us to analyse and evaluate what we did and helped us be quite honest with what we were doing with our groups to improve them. And obviously, none of this was possible without the lovely support from our educators, which were Sharon, Marshall and Liz, so who helped us make this possible. So yes, and that is the end of the evaluation slide. If you could just go next slide, please, and then you'll be able to see our lovely little outcome measures of their smiley faces. So what did we do well? What did we not do well? And what was your favourite part? And as we said, a lot of the patients absolutely loved just getting to know us, just loved having a chat with us. They loved the origami. They loved the chance to interact with other patients. And like Chris said, this really helped to improve their well-being. Ladies, I don't know if you want to add anything on to the end of that. Thank you very much.